Welcome back to the deep dive. If you're looking for a fast track through the essentials of upper GI disorders, you're definitely in the right place. Today, we're really digging into stomach issues, gastritis, peptic ulcer disease, PUD, and some critical care stuff too.
Right.
It's all coming straight from a core med-surg nursing text. Basically, we're pulling out all the need-to-know info for you.
Right. And to keep it organized, we're looking at this through four main concepts. You've got infection, think H. pylori with PUD, then inflammation, obviously. Nutrition is a big one. Often altered nutrition is a risk. And of course, managing pain. These really tie everything together.
Okay, let's unpack this then. Starting at square one, gastritis. So basically inflammation of the stomach lining, the gastric mucosa, and the source differentiates between acute, which usually clears up on its own, and chronic, which is more sneaky and can lead to atrophy over time.
Exactly. And the core problem, the pathophysiology, boils down to a breakdown in the stomach's defenses. See, the lining depends on this protective barrier maintained by prostaglandins.
Prostaglandins, okay.
Yeah. If that barrier gets damaged, the hydrochloric acid inside the stomach can seep back into the tissue. That injures blood vessels, causes swelling, edema, and can lead to bleeding, even erosion.
So this is where, patient teaching becomes so critical. The source points out that a major cause of acute gastritis, that sudden barrier breakdown, it's often linked to something people take all the time for pain.
You got it. Long-term or heavy NSAI use, ibuprofen, naproxen, things like that. NSAIDs actually work by inhibiting prostaglandin production.
Oh, okay.
So the very thing you take for a headache could be weakening your stomach's defense. Then add in common irritants, alcohol, coffee, caffeine, definitely stress, smoking, and, well, you've got a recipe for acute inflammation.
That really needs to be hammered home. Okay, now chronic gastritis. You said it leads to atrophy. What's the main driver behind the chronic type, and why does it matter beyond just a stomachache?
So the most common form, type B, is usually caused by Helicobacter pylori infection, H. pylori. As that inflammation sticks around, it starts destroying the stomach's secretory cells, the parietal cells.
And those make?
They make intrinsic factor. An intrinsic factor is absolutely essential for absorbing vitamin B12. So no intrinsic factor means no B12 absorption, which eventually leads to severe B12 deficiency and pernicious anemia.
Wow. That's a huge leap from a stomach bug to a blood disorder.
It really is a crucial connection to make.
So clinically, how do the symptoms differ? How can we tell acute from chronic just based on what the patient reports?
Well, acute gastritis hits fast,
Huh.
often intense upper stomach pain, dyspepsia, that classic heartburn or indigestion feeling. And if there's bleeding, you might see hematemesis, vomiting blood, either bright red or like coffee grounds or melena, those dark, tarry stools.
Got it. In chronic?
Chronic is often much vaguer, maybe just some nausea, vomiting, general upper abdominal discomfort. Sometimes the symptoms are more related to an ulcer that's developed alongside it.
Okay, so if someone comes in with these symptoms, what's the workup? Can't just guess,
Yeah.
right? Especially with cancer being a possibility.
Absolutely not. The gold standard, the definitive test, is an esophagogastroduodenoscopy and EGD with biopsy.
The scope.
Exactly. Lets the clinician see the lining directly, take tissue samples to confirm gastritis, check for H. pylori, and crucially, rule out any malignancy.
Makes sense. So management starts with getting rid of the cause, right? Stop the NSAIDs, cut out the irritants. But for immediate relief, the text mentions H2 blockers and PPIs. Is it just about how strongly they work?
Pretty much. H2 receptor antagonists, like famotidine, they block secretions. PPIs, proton pump inhibitors, are generally stronger. They suppress acid production itself. Both are key for supportive care.
And for the chronic cases?
Yeah, for those chronic cases, especially type A leading to pernicious anemia, you'll need that vitamin B12 replacement. And always, always reinforce the lifestyle stuff. Balanced diet, regular exercise, stress management, avoiding alcohol, tobacco, spicy foods. All that is vital to prevent it coming back.
Okay, let's shift now to peptic ulcer disease, PUD. This is where that mucosal defense has really failed, and the stomach or duodenal lining is exposed directly to acid and pepsin.
Right. And with PUD, location really matters. You need to know the difference between duodenal ulcers and gastric ulcers.
Okay, let's start with duodenal. What's the key feature there?
Duodenal ulcers are more common. The big thing is usually hypersecretion, too much gastric acid. And the pain pattern is classic. It hits maybe 1.5 to 3 hours after eating, often wakes the patient up at night. But here's the key. Eating food often makes the pain better, temporarily anyway, because it buffers the acid.
Okay, pain after eating gets better with food.
Got it.
And gastric ulcers.
Gastric ulcers are in the stomach itself, often the antrum. They're sometimes linked to issues with the pyloric sphincter, causing bile to reflux back into the stomach. Gastric emptying can also be delayed.
And the pain?
The pain is almost the opposite. It tends to occur sooner, maybe 30 to 60 minutes after a meal, and eating makes it worse.
Worse.
Yeah, which is why patients with gastric ulcers might actually avoid eating and can sometimes become malnourished.
That's a really important distinction. We should probably also just quickly mention stress ulcers.
Right, briefly. These are acute lesions you see after major physiological stress like sepsis, big surgery, severe burns, that's a Curling's ulcer, or a significant head injury, which is called a Cushing's ulcer. The main issue with them is usually sudden, severe bleeding.
Okay. So digging into why PU happens, the text really narrows it down, doesn't it?
It really does. It's overwhelmingly caused by two main culprits: that bacteria, H. pylori, and long-term NSAID use. H. pylori is clever. It makes urease to neutralize acid around it, letting it burrow into the mucus layer where immune cells can't easily get it.
And the NSAIDs just keep chipping away at that mucus layer.
Exactly. It's a dangerous combination.
Now let's talk complications. This is high alert stuff. Hemorrhage the most serious. What are we looking for beyond just seeing blood?
Hemorrhage means significant blood loss, fast. So yes, look for hematemesis, the vomiting blood, or melena, the tarry stools. But systemically, you need to watch for signs of shock, hypovolemic shock. That means blood pressure dropping, heart rate shooting up to compensate, weak pulses, the patient feeling dizzy or lightheaded.
So treat for shock immediately.
Immediately. ABCs first, always.
Okay, another major red flag, perforation. The text says if that ulcer pain suddenly changes, it becomes sharp and spreads. That's bad news. Why is spreading pain such an emergency?
Because it means the ulcer has eaten all the way through the stomach or duodenal wall. Contents, acid, enzymes, food, bile are spilling into the peritoneal cavity. It's a massive infection risk, peritonitis. A surgical emergency.
And the classic sign-on assessment.
Sudden, sharp, spreading pain, yes. And when you examine the abdomen, it'll be tender, rigid, and often described as board-like. That board-like abdomen is the hallmark of peritonitis. Get surgery involved, stat.
And the third complication mentioned is pyloric obstruction. Scarring or swelling blocking the stomach outlet. What does that lead to metabolically?
Right. If the stomach can't empty, the patient will vomit a lot, leading to gastric dilation. They're losing large amounts of hydrochloric acid in the vomit. This throws off their electrolytes and acid-base balance, causing metabolic alkalosis and low potassium hypokalemia. Need to watch those labs closely.
Okay, shifting to actually treating PUD. The goals seem clear. Relieve pain, kill the H. pylori, heal the ulcer, stop it from coming back. How do we tackle the H. pylori specifically?
The standard approach is often called PPI triple therapy. That's a proton pump inhibitor plus 2 antibiotics. Common combos are metronidazole and tetracycline, or maybe clarithromycin and amoxicillin, usually for 10 to 14 days.
And if they're allergic to penicillin?
Then you might move to quadruple therapy, which adds bismuth subsalicylate, like in Pepto-Bismol, to the PPI and 2 other antibiotics.
Okay, and there's a little action alert about bismuth, right? Something patients need to know.
Yes, absolutely. You have to tell patients that bismuth can temporarily turn their stools black, and sometimes even their tongue. It's harmless, but if they see black stool, they might panic thinking it's melena, digested blood, so you have to pre-warn them.
Good point. Crucial teaching. Now, let's say a patient is actively bleeding, upper GI hemorrhage, critical rescue time. After ABCs, what are the immediate nursing priorities for circulation mention?
Volume, volume, volume. Get oxygen on them for sure. Then start 2 large bore IV lines. We're talking 18 gauge or bigger if possible. You need rapid infusion capability.
Cool.
For isotonic fluids first, normal saline, lactated ringers to restore volume, and then blood products if their hemoglobin is low or they're unstable. And obviously, constant monitoring of vital signs, urine output, mental status, continuous assessment is key.
Okay, once they're stabilized a bit, how do we actually stop the bleeding non-surgically?
Often an initial step is placing a nasogastric tube, an NGT. This helps see how fast the bleeding is, decompresses the stomach, and allows for lavage, flushing the stomach with room temperature saline until the fluid coming back is clearer.
But the definitive treatment is usually
Endoscopic therapy done via EGD. The gastroenterologist goes in with the scope and can directly treat the bleeding site. Maybe inject chemicals, use heat or laser, or apply clips to close off the bleeding vessel.
And the really critical safety check after any EGD.
The gag reflex. Their throat is numbed for the procedure. You absolutely cannot give them anything to eat or drink until you've confirmed their gag reflex has fully returned. Otherwise, the risk of aspiration is huge. Check it again.
Got it. Okay, before we wrap up the stomach stuff, we should probably touch on the worst case scenario, gastric cancer.
Hmm.
The text links it back to some familiar culprits.
Yeah, unfortunately, most gastric cancers are adenocarcinomas, and the biggest single risk factor, again, is chronic H. pylori infection, especially certain strains that carry specific genes like KAGA. Other risks include that chronic atrophic gastritis we talked about, pernicious anemia, and diets really high in pickled foods, nitrates, and salt.
And if surgery is needed, like a gastrectomy, what's a major focus beforehand?
Nutrition. Patients with significant stomach cancer are often severely malnourished. So, before they can safely have major surgery, they might need nutritional support, sometimes enteral supplements, sometimes even TPN, total parenteral nutrition, to build them up. Post-op, especially after a big resection, the big challenge is often managing how quickly the stomach empties, or what's left of it.
Which brings us to the infamous dumping syndrome. Can you define what's actually happening there?
Sure, dumping syndrome occurs when food, especially sugary or high-carb food, moves too quickly from the stomach pouch into the small intestine. This very concentrated load pulls fluid rapidly from the bloodstream into the bowel by osmosis. That causes abdominal distension, bloating, and systemic symptoms because of the fluid shift.
Right, and there are two phases of symptoms, early and late.
Exactly. Early symptoms hit within about 30 minutes of eating. The patient feels vertigo, tachycardia, a racing heart, sweating, looks pale, and often feels this overwhelming urge to lie down.
Okay, that's early. And late.
Late dumping happens maybe 90 minutes to 3 hours after eating. It's caused by a rapid spike in blood sugar from the quick absorption, followed by an overshoot of insulin release. This leads to symptoms that feel like hypoglycemia, dizziness, palpitations, sweating again, maybe confusion.
So managing this is all about the diet,
Right.
right? What are the absolute must-know dietary rules?
It's very specific and critical teaching. First, small, frequent meals instead of 3 large ones. Second, the diet itself should be high in protein and fat, but low to moderate in carbohydrates, especially simple sugars. And the really key one, patients should avoid drinking liquids with their meals.
No liquids with meals. Why is that so important?
Because liquids speed up gastric emptying even more. They should drink fluids maybe 30, 60 minutes before or after meals, but not during. That helps slow things down and reduce the dumping symptoms.
Okay, that's a lot of crucial detail.
Yeah.
So bringing it all together for the listener, what are the absolute non-negotiable takeaways from this deep dive? The things you just have to remember for safe practice.
Okay, 3 big ones. First, know those ulcer pain patterns. Duodenal, pain after food, often at night, relieved by eating. Gastric, pain shortly after food, worsened by eating. Helps you anticipate problems.
Right.
Second, that critical safety sign. If ulcer pain that was intermittent suddenly becomes constant, sharp, spreading, and the abdomen feels rigid, board-like, think perforation and peritonitis, that's a surgical emergency. Act fast. And third, remember the diagnostic hierarchy. Don't guess. An EGD with biopsy is essential for confirming gastritis or PUD, checking for H. pylori, and ruling out cancer. It's the gold standard for a reason.
Perfect summary. And finally, just a thought to leave everyone with. We focused a lot on the physical causes and treatments, the bacteria, the meds, the surgery. But the source material also mentions how things like PUD and gastritis are often worsened by emotional stress, that whole brain-gut axis idea.
Definitely.
So it makes you wonder, if stress is a known factor, how much should we be integrating real stress management techniques into the core treatment plan? Not just as an add-on, but maybe as something fundamental to preventing these conditions from coming back long-term.
That's a really powerful point. The connection is definitely there and maybe underutilized in the standard practice. Something to think about.
Absolutely. Well, thank you for joining us on this deep dive into stomach disorders. We really hope distilling this information helps you feel more confident in your understanding and practice.